Talk to us a little bit about what is going on in the world of
Treatment?
general treatment for colorectal cancer, and also the world of screening.
Well, in terms of treatment, we've had a couple setbacks. Last year, we learned that the anti-angiogenic bevacizumab did not improve overall survival in early stage colon cancer, meaning stage 2 and 3. And this year, a much awaited trial, the first one to look at the biologic cetuximab in stage 3 colon cancer, was presented. The trial was actually halted early back in November when we found that patients did no better when they were given chemotherapy and cetuximab. Now, these are cured patients, so we're treating risk of metastatic disease or micrometastatic disease. And we want to make that cure rate higher, and we didn't. And it doesn't make a lot of sense. Bevacizumab works in advanced disease, but it doesn't work in early stage disease. And we are now seeing that the epidermal growth factor inhibitors may not be effective either in eradicating micrometastatic colon cancer. And I just think it makes us want to question whether the treatment of disseminated tumor cells or micrometastatic tumor cells actually have to be thought of as a novel disease process. And we can't always assume, at least in colon cancer, that drugs that work in metastatic tumors are going to necessarily work in early stage tumors. In terms of screening, I think it's clear that patients benefit from screening when they're above age 50. And patients with first-degree relatives with colon cancer have to actually be alert to an elevated risk. And we tend to screen those patients at the age 10 years before the age of onset of a family member.
Well, this is where gathering family history is so important. You know, as of late, I've been meeting quite a few young adults with colon cancer. And that's not a patient population one really expects to see with this disease.
We know that in African Americans there's a shift to younger age, and the guidelines now include screening at age 45. But I think we need to see if there'll be an epidemiologic shift in age of onset. I don't know if that's true across all populations as of yet.
Right now, maybe a very early research, but what is going on in the study of treatment for colorectal cancer that maybe still early in the research stage, but where you have your eye out for the near future?
Well, I mean, there's been some interesting reports in JAMA of aspirin in a large study where patients were taking aspirin after therapy for colon cancer. We saw a 20% reduction in recurrence. So I think there may be some COX-2 expression in colon cancer, and perhaps future trials will look at aspirin. We're looking at another large trial, statin use, to try to evaluate in a randomized prospective trial whether those drugs can be helpful in preventing colon cancer. So those are trials that are now ongoing. And I think the most interesting area, or one of the most interesting areas in colon cancer, is patients with isolated metastatic disease to the liver. There really is a subpopulation of patients that can be cured with metastatic disease, and we're trying to ferret out well in research studies who those patients are, how to best treat them, how to convert them to where they can be resected.
Thank you, Dr. Obel.